Hello and welcome to this learning module where we will discuss the role of the medical director in an EMS system. We will also provide an overview of quality improvement in EMS. This video is intended to supplement any readings or coursework assigned by your instructor. The objectives for this learning module are: number 1, describe the role of medical direction in an EMS system. Number 2, define quality assurance and quality improvement. Number 3, discuss the EMS provider's role in the quality improvement process. EMS systems retain the services of a physician medical director to oversee key components of the system's operations. The South Carolina EMS Regulation 61-7 explains that the medical director is responsible for providing oversight to ensure that all EMS personnel are properly educated and certified, provide oversight to ensure that an effective method of quality assurance and improvement is taking place, and to develop the agency's medical protocols. Medical directors may also participate in the new hire selection process, make recommendations for equipment, provide continuing education for providers, and serve as a liaison between the EMS system and the local healthcare system. Some EMS medical directors are provided a response vehicle like the one seen here to respond to large-scale incidents and support their crews. Since EMS providers operate with the oversight of an agency medical director, procedures must be in place for times when the medical director is not physically present. There are two types of medical control that enable EMTs and paramedics to provide care. Online or direct medical control is medical direction provided by a base physician directly to an EMS provider by radio or phone. In many areas, online medical control is provided by the emergency department physician at the facility that will be receiving the patient. In the image on the left, we see a physician providing online medical direction to an EMS crew. Offline or indirect medical control is medical direction that's provided through a written set of protocols or guidelines. The EMS system's medical director is responsible for developing and updating the offline medical control protocols. The South Carolina EMS Regulation 61-7 defines protocols as written order signed, dated, and issued by a medical control physician that allow EMT basics, advanced EMTs, and paramedics to administer particular medications and perform treatment modalities in specific situations without online medical control. The regulation goes on to mention that EMS protocols may also be referred to as standing orders. In the image on the right, we see the South Carolina EMS protocol for a pediatric multiple trauma victim. So what is quality? We all have our own idea of what quality is when we are asked this question. By definition, the term quality refers to a degree of excellence. Our goal as EMS providers should be to provide the highest degree of excellence in patient care to the individuals who request our assistance. When we talk about terms like quality assurance and quality improvement, they are often used interchangeably, but they have two very distinct meanings. Quality assurance, abbreviated QA, is the planned system-wide evaluation used to ensure that clinical care is delivered in a manner consistent with existing standards and guidelines. QA helps us detect an error in care after the error has happened. Errors are commonly found during a review of a patient care report by a supervisor or a peer. QA is a process that looks at current practice. When an area for improvement is identified, a quality improvement or QI process is implemented to determine whether changes to a current practice lead to the desired improved results. The goal of QI should be to develop a reliable system that operates in a relatively error-free state over a long period of time. In short, quality assurance is a reactive process, while quality improvement is proactive. Many EMS systems use quality assurance to identify problems and will then implement a quality improvement process to evaluate possible enhancements. Before we begin a quality improvement process, we need to answer three fundamental questions. Number 1, what are we trying to accomplish with this process? Number 2, what should be measured and how should it be measured? Number 3, What changes can we make that will result in process improvement? The image on the slide illustrates the Institute of Healthcare Improvement's Continuous Quality Improvement, or CQI model, that is most frequently used by EMS systems across the country. The Plan, Do, Study, Act, or PDSA cycle. During the plan stage, we need to clearly define the project objective to ensure it aligns with what we are attempting to accomplish. We also need to brainstorm multiple solutions to select the best one to apply. Lastly, we need to develop a plan to test and implement the selected solution. During the Do phase, we will execute the plan. Many experts recommend performing a small trial of the change prior to rolling it out system-wide. For example, pick one shift to try the solution to see how it works prior to implementing the change throughout the entire system. Frequently, this small test will help us identify areas that need to be addressed before introducing the change throughout the system. During the study phase, we review the results to determine if the changes we implemented resulted in process improvement. During this phase, the team reviews what aspects of the plan went well and what components of the plan did not. The last stage of the cycle is the Act phase. During this phase, the team makes the determination to permanently implement the process change that was tested or to evaluate additional adjustments prior to making a permanent change. Deployment of the new process is dependent upon the results of the study phase. If the desired outcome was not reached, then the cycle of Plan, Do, Study, and Act is implemented again. For quality improvement to be effective, QI programs should not use a punitive approach. A just culture strategy holds the entire organization responsible for improving the system and its processes. Many EMS systems employ a just culture approach that encourages providers to report any errors or near misses. The Institute of Medicine defines a near miss as an error of commission or omission that could have harmed the patient, but serious harm did not occur as a result of chance, prevention, or mitigation. An error of commission is when the healthcare provider does something wrong, while an error of omission is failure to do something that should have been done. So to summarize, a near miss is an unplanned event that could have caused injury, illness, or damage, but didn't. When using a just culture strategy, a near miss is just as important as an actual error. The benefit is that the near miss can be addressed and processes changed to prevent future errors. The just culture strategy promotes education over punishment. It also promotes provider accountability while working to improve system safety and improve patient outcomes. This concept will be discussed in greater detail throughout your training. There are different ways an EMS provider can participate in and support quality assurance and quality improvement activities within their agency. Foremost, EMS providers must take accountability for medical errors and near misses through the reporting process available at their agency. Additionally, providers should actively participate in QA and QI activities that are sponsored by their employer. Many EMS agencies tailor their continuing education activities to concerns that arise from the department's QA and/or QI initiatives. EMS providers should actively participate in these continuing education opportunities. Lastly, EMS providers should have the opportunity to interact regularly with their medical director. A large number of EMS QA and QI processes are committed to minimizing medication errors in the pre-hospital setting. Approximately 7,000 to 9,000 people die in the United States each year because of a medication error. The total cost of looking after patients with medication-associated errors is estimated to exceed $40 billion annually. While there are no definitive statistics available about EMS medication errors, some studies suggest anywhere from a 13% to a 31% medication error rate. Advanced EMTs and paramedics can administer more medications than EMTs, and most of these medications are administered via injection into the muscle or through an intravenous line. When a medication is administered by injection, there's very little that can be done to reverse it. EMS medication errors can include administration of an incorrect medication, under or overdosing a medication, drug calculation errors, and failure to follow agency protocols. The best way to prevent medication errors is to actively communicate with your partner to ensure that the right medication is going to be provided at the correct dose and via the correct route of administration. If a medication error occurs, the EMS provider should immediately contact online medical direction to notify the base physician of the error and determine what, if anything, can be done to help the patient. Additionally, this information must be provided to the receiving facility in the patient handoff at the emergency department. Failure to do this could lead to a poor outcome for the patient. Here's a list of references used to create this learning module. This brings us to the end of this presentation. Here we see the learning objectives for this module. Can you demonstrate each of these objectives? If not, please consider going back to review any content that you struggled with. Thank you for watching this learning module.